Good evening, everybody. Welcome to tonight's Transplant Talk Live, Arrow, the Bone Marrow Transplant Foundation's webinar series. These webinars are an opportunity for us to delve deeper into the world of BMT and CAR-T related topics, with tonight's topic focusing on CAR-T with long-term and late effects in the paediatric setting. I'm Angela. I'm the Patient Liaison Officer at Arrow, and I'm coming to you tonight from the lands of the Wadawurrung people in the Geelong region. I have with me today our wonderful host, Yvonne Panic-Hudson. She is a clinical nurse practitioner in haematology at both Peter MacCallum Cancer Centre and the Royal Melbourne Hospital. Yvonne is also the co-host of the fabulous and very informative podcast, The Straight and Marrow. And she is also a director on the Arrow board. Yvonne is joining us tonight from the lands of the Wurundjeri people in Melbourne. Along with Yvonne, we have our very wonderful guest speaker, Maddie Gilsenan, and she is from the Royal Children's Hospital. She is a paediatric bone marrow transplant and cellular therapies nurse practitioner. And she's also joining us from the traditional lands of the Wurundjeri people. I'll shortly hand over to Yvonne, who will also be facilitating our Q&A section of tonight's webinar. So if you do have any questions that arise throughout the session, please pop your questions into that area and we will be monitoring it throughout the night, and we will get to that on the conclusion of Maddie's presentation. And we will do our best to answer your questions. Please keep in mind that we are unable to answer any medical specific questions relating to your own healthcare needs. So please, if you do have any questions arising from tonight's webinar, consult your healthcare team and they will be able to help you out further. So without further ado, enjoy tonight's webinar and I will hand over to Yvonne.
Thanks, Ange, and welcome everybody. I can see we've got almost 20 participants on, and I'm sure there's more to come. As Ange said, my name's Yvonne Panic-Hudson, and I'm really delighted to be hosting tonight's webinar featuring Maddie Gilsenan, who is a nurse practitioner from the Royal Children's Hospital. Maddie is an really extraordinary human being and has dedicated her career to the care of young people having allogeneic stem cell transplants and CAR T cell therapy. And she's going to tell you all about that tonight and share her knowledge, both about caring for patients in the preparation for transplant and CAR T therapy, but, you know, really importantly, the supportive care that people require after they've received their infusion and their transplant. So I'm really delighted to be hosting this. I'm going to bring Maddie in now, who's going to share her slides with you, and then we will have a Q&A at the end. So write your questions down, and looking forward to hearing them at the end of Maddie's presentation. Thanks, Maddie.
Thank you for a very kind introduction. Can you see my slides okay here? Perfect. Yes. So yeah, thanks so much for having me. I'm obviously very passionate about CAR-T. It's what I spend most of my days talking about. So very happy to be able to, I guess, share some of our experience in caring for paediatric patients who have undergone CAR-T therapy. So I work at the Royal Children's Hospital in Melbourne, but I think we have a really close collaboration with all of the Australian paediatric centres and who deliver CAR-T or who are referring patients for CAR-T. So I think all of the information that I'll talk about is very relevant to anywhere in Australia and New Zealand that children may be receiving CAR-T therapy. So I'm just going to talk, I know I'll spend a little bit of time focusing on late effects and some of the surveillance and things that we're monitoring for after patients have had CAR T cell therapy. But I thought it's just useful to always have a little overview about what CAR T cell therapy is. What are some of the CAR T therapies that are available in the paediatric population? And a little bit of our activity over the past 5 years. and a brief overview of what the CAR-T treatment pathway is, just to get an idea of potentially some logistical arrangements, and maybe if you're yourself or your child is preparing to undergo CAR-T cell therapy, what are some of the things that you might need to consider in the lead up. And then in the last 10 minutes or so, I'll focus on the late effects that we know to date. So I'm not sure how much people know about CAR-T. It's a very, novel therapy. Lots of work has gone into CAR-T therapy, particularly in the last 5 to 10 years. The first paediatric patient to receive CAR-T for relapse pre-B ALL was 11 years ago now. So I guess we don't have as much long-term data as we do for, standard of care treatments, more so like allogeneic bone marrow transplant. But I think now worldwide, we do have a lot of international experience with CAR-T in the paediatric setting. And I guess are always learning new things. There's always new research going into the CAR-T space. And then it's really good to be able to present back sort of what we found and with our experience as we treat more patients. So CAR-T is all about, retraining a patient's own immune system to fight off their leukemia. So historically, when children with ALL or pre-B ALL didn't respond well to treatment, we potentially increased the intensity or intensified their chemotherapy regimes, which we know that sometimes will just cause a lot of side effects and potentially not provide any benefit if they're particularly chemorefractory or not responding to chemotherapy. So CAR-T is a type of immune therapy. And as I said, it's all about, enhancing a patient's own immune system to recognize and fight off their leukemia. So the most established CAR-T therapy in the pediatric space so far is a CAR-T product called Kymriah that is a CD19 directed therapy. So at the moment, this is actually a standard of care. It's been through the clinical trial phases and is now sort of readily available for our patient group who meet the, national eligibility. There is a little bit of a strict eligibility, but it is something that we've been delivering now for 5 years as a standard of care therapy. It is a little bit of a complex treatment in that it involves a few stages, and it's all about, it stands for CAR, stands for chimeric antigen receptor, and it's about engineering a patient's own T cells. So those really important cells in the immune system that can recognize cells that shouldn't be there. So any abnormal cells, your T cells normally recognize them as foreign, whether that be a virus or whether that be an abnormal cell or a leukemia cell or a pre-leukemia cell, and it's able to recognize that as foreign and get rid of it. So in this situation, we're really retraining a patient's own T cells to recognize those cells as foreign and to get rid of those. And that involves taking a patient's own T cells through a process called apheresis, sending them away to be manufactured or engineered with a CAR. And that is chosen for a specific receptor that's on the outside of the patient's cells that's specific to their leukemia. And then the cells are sent back to our centre and infused into the patient. And how I explain this to our younger patients is that we're retraining their cells to make their abnormal cells much more obvious. And it's essentially like their abnormal cells are holding up a little bit of a red flag, and the T cell is able to go in and get rid of those cells. So it's all about retraining the patient's own immune system to fight off those cells. And we know that by giving, so when we give chemotherapy to patients, we know that chemotherapy just targets any cells that are rapidly dividing. So it's not able to be essentially something that is really specific. But with CAR-T, we know we're targeting a specific cell. And so that's why we tend to see less side effects than if we are treating a patient with chemotherapy, because we're able to be really specific in the cell that we're trying to target, rather than just targeting sort of all of the cells that are there in the bone marrow. So with this particular product that we give for relapse pre-B ALL, which is our standard of care option. We are giving this with the intent as a long-term curative treatment option, so long as the CAR T cells, we say, persist or are staying around long-term. So that is the hope. That is what we have achieved in many patients. But it's something that we need to monitor really closely. Whereas some of the other immune therapy options that we've been using, such as drugs, maybe like blinatumomab or inotuzumab, we're more using those therapies as a bridge to something more long-term curative, such as bone marrow transplant, when we're dealing with the relapse leukemia situation. So there is one, as I mentioned, CAR T product available in Australia and New Zealand for the paediatric population at the moment. This is the product I was talking about before, that's for CD19 or B-cell leukemia. And the criteria for this is we're not necessarily using this as more upfront therapy. We are using this for children whose leukemia has proved refractory or have had multiple relapses. So we classify that as 2 or more relapses, which can be in the marrow or the CNS alone, or combined relapses. Any relapse after a allogeneic bone marrow transplant, or patients who show us that they're refractory to chemotherapy. So we've given first line, second line chemotherapy, and there is still some leukemia present. Or children who have completed all of their leukemia therapy and potentially had a relapse and then still had some disease detectable after 1 cycle of reinduction therapy. So it's not at the moment currently used in more upfront therapy. It's tend to be used for children who have had relapses or potentially relapse post-transplant. It is a treatment that children are eligible for once, so we are always very selective about the timing that we are using this treatment option. And very excitingly, so obviously when new treatments become available, they need to be tested in the adult space before they come to and are available in the pediatric setting. So it takes a little bit longer for us to have clinical trials available in the pediatric space. And then usually trials will open maybe from 12 years and above. But we excitingly have a new CAR T product coming in the coming months in our hospital in Melbourne for T-cell ALL. That has been available in the adult setting so far and the above 12 years of age, but will soon be opening for patients with relapsed refractory T-cell ALL. And the target for this is patients with CD7, which is mostly present in children with sort of relapsed refractory T-cell leukemia. This is still early phase clinical trial in the paediatric setting, so it's not a standard of care treatment and will be through a clinical trial and is still experimental. So it's been through the safety testing phases, and now we're sort of looking at efficacy. So that is something that's coming and really exciting, that we're able to be expanding our CAR T program. Because I know there's a lot more CAR T products available in the adult space, but as I said, it takes a little while to filter down to the pediatric setting. So although patients might meet this eligibility criteria for CAR T, there is often a lot of discussion between healthcare professionals, whether it's the referring clinicians or the CAR T centre. We have a lot of discussions about when is the ideal time to provide CAR T therapy, and that very much differs between patients. It's discussed at a national level on a case-by-case basis. So some of the advantages of CAR T, and potentially sometimes when we're looking at the differences between if we have a child with relapsed ALL, pre-B-ALL, who potentially we're deciphering the next treatment schedule, which may be bone marrow transplant or CAR T. What are some of the things that we think about for children having CAR T therapy or considering CAR T therapy? One of the biggest things is that CAR Ts are sort of made and they are ready to go and ready to start fighting disease. And they work very quickly, which is excellent, but they also are really excellent at traveling into the central nervous system, so into the spinal fluid, and crossing over that blood-brain barrier. And that is really, really excellent for children who have had leukemia present in their spinal fluid, that sometimes can be a little bit difficult to target unless we're giving intrathecal chemotherapy. So that is one of the big considerations, and where we've had a lot of good outcomes for children who have had prior relapses of CNS leukemia, and that has usually been a very clear indication for CAR T therapy. We know that, as I said, the CAR Ts are very specific to the B cell, so they're really only targeting those little proteins that are on the outside of the B cell, and that means that we're not causing too much significant, I guess, long-term effects on other organs, whereas a lot of the time when we're giving other therapies like intensive chemotherapies, they're targeting a lot of other cells and not just specific to these cells. So that's important when we consider long-term side effects. We know that the period of immunosuppression is generally much shorter than the transplant setting, and the risk of, I guess, when we're considering allogeneic transplant, because we're taking cells from the patient, training them and reinfusing them, the risk of graft-versus-host disease that we can sometimes use when using donor cells is significantly reduced because we're using the patient's own cells. So there's some of the things that we think about, but when reflecting back on the children that we've treated in our centre, I think children who present to us with extramedullary disease, so usually in the central nervous system, are usually quite a clear indication for CAR T. So at the moment, so when the CAR T program first opened, at the Royal Children's, we were the main centre providing this therapy. So patients and families were travelling to and from our centre, which is a huge, I guess, logistical issue and really difficult for patients and families. And although we have a really strong collaboration with our national centres, as I mentioned, it's been really great that over the past few years, we've had some other centres in Australia open up to be able to deliver CAR T. So that is Sydney Children's Hospital, Westmead Children's in Sydney, and Queensland Children's, which is really excellent for patients not having to travel as far. So I always just like to show a little overview of our program at the Royal Children's. So we actually participated in the first international clinical trial for Kymriah, or the CD19 B-cell CAR product, which was in 2015 when that first opened, and we treated one child before the study closed to recruitment, and it was undergoing the approval process to become a registered product, which it now is. So we closed for a little period, and then we reopened our standard of care sort of commercial program in October 2019. And we have treated 31 patients to date, which compared to the adult population is not a huge number, but considering that the population of relapsed refractory B-cell patients in the paediatric setting is small, it is a decent number, and we've been able to learn a lot from the patients and see a lot of trends over the past 5 years. And I guess the main thing I wanted to show from our activity here is that particularly when we first opened and when there was no other paediatric centres open from 2019 sort of to 2021, that's where we were treating a lot of children, particularly from interstate centres, which is really tricky for patients and families to be having to travel, usually not long after finding out about a relapse, and having to move to a centre that they don't know the clinician. So really, really difficult. But that has allowed us, I guess, to learn a lot in that period from these patients. And this is just to show a little summary of sort of where our patients have travelled from. But so we've sort of seen patients from a lot around Australia and New Zealand, but really excellent for patients and families that there are centres closer to home now, which they're able to access. So to help understand some of the long-term effects, I think it's really helpful to understand the treatment pathway of CAR T, or potentially if yourself or your child, or you have a child preparing for CAR T therapy, what that looks like, and logistically some of the challenges around moving through centres. So the CAR T treatment is sort of broken up into 5 phases. As of the last 2 years, we have aimed to provide majority of our CAR T therapy to patients as outpatients. And that's definitely where things are moving, I guess, in all aspects of care in, I guess, the oncology setting. But obviously there are some situations where children will need to come into hospital, and this has evolved also. I guess our program has evolved as we've learned more lessons, we've become really comfortable with managing these patients. And so the initial phase is obviously when a new patient is referred to our centre and when they need to have their cells collected. Then the second phase is the bridging phase, when the CAR T cells are being manufactured, and that process takes around 4 weeks. Then patients will return to us for some chemotherapy that will just makes some space in the bone marrow for those CAR T cells to grow when we infuse them. And then the infusion itself. And then the acute sort of surveillance period is usually about 4 to 6 weeks post-infusion. And then the more late effects are sort of after that 6-week period. So I'll just briefly talk through the different stages. So when a child is referred to us, it's referred to our head of the CAR T service. We discuss the case at our CAR T multidisciplinary meeting within our hospital. And then also we have a national CAR T meeting every Tuesday where all of the paediatric and adult new referrals are discussed. So lots of discussion about these patients to confirm their eligibility. So the next phase is the patient is sent to us for the collection of their cells. And if they're from an external centre, they're normally spending around 1 week at our CAR centre. And during that time, we're usually meeting families for the first time. We're really assessing the child, I guess, developmentally and neurologically is a really big consideration when we think about some of the side effects. So it can be really hard to assess a child that you've not met before. So we spend a lot of time really getting to know patients and families, and that really helps us in the long run for our monitoring. Obviously, in the paediatric population, we really like to understand maybe procedural challenges that they have had and things that we can do to make things easier for the children when they come to us. In the adult situation, I guess the adult setting, to have the actual cells collected themselves, which is usually a very boring process for the patients. It takes about 4 to 6 hours. It's sort of like, I guess, when you donate blood or patients that are having dialysis, they're connected to this machine that you can see in the picture. But we normally have to put a large sort of catheter in called a VAS cath for children because their veins are normally quite small. So it can be a little bit more logistically challenging than in the adult setting where we can just put 2 sort of big cannulas in. So all these things that we need to think about. We need to do a lot of screening for infection before we take some cells, and that's really when we start introducing patients to our team. We have a lot of teams involved within our hospital who care for patients having CAR T cell therapy. So that whole process is generally around a week at our centre. We've just finished making, which will soon be available on our intranet, 2 patient orientation videos, which I hope will be really helpful for patients preparing for this therapy. And we have a child that walks through the process of what this looks like for both apheresis and infusion. So hopefully that will be really helpful, and it will soon be available on our intranet for anyone to be able to access. So the second phase of the process is the bridging therapy process. So that's when the CAR T cells are being manufactured overseas, and we just need to provide some treatment for children to control their leukemia. We need to make sure we're giving something in that period. And the aim is that we are not completely trying to get rid of all of the leukemia. It's just to keep everything under control and the patient's well until they're ready for their reinfusion. And that's when we start getting ready at our hospital for the return of the patient. We tend to do this in the outpatient setting, and usually it's about a 4 to 6 week process. And patients can return back to their home centres for that period if they wish. And so once we've got the patient, so we've got the cell notification that the cells have been manufactured okay, the patient has returned to us, then we're getting ready to reinfuse the cells. And this is when patients and families have to relocate within sort of half an hour to an hour of a CAR T centre for 30 days, or 5 weeks in total, including the week of the preparation. So obviously another big consideration, particularly for families who are potentially living interstate and having to travel to Melbourne or to their CAR centre. So definitely a logistical consideration. We have a lot of families that relocate their whole family for this period and really just support whatever is most helpful for the patients and families. The CAR T infusion is usually very exciting. It's usually extremely uneventful. And we just give 4 days of chemotherapy in the lead up to the cell infusion, which is definitely not as intensive as the preparation for a allogeneic bone marrow transplant. But it's really just to make some space in the bone marrow for the cells to expand and grow once we infuse them. And so children will come to our day oncology clinic every day for that chemotherapy and then back for the infusion of the CAR T cells. And then patients are monitored very closely for any side effects within the first sort of 30 days of the infusion. A couple of the toxicities that I just wanted to talk about, and I think what we've learned to spend the last sort of 10 minutes or so talking on these things, but there's specific sort of acute and then late effects that we look for with CAR T. And I guess one of the beauties of this therapy is that the late effects is not a huge list, which is good, but obviously we're still learning things every day about this treatment. So the more acute side effects that we see are related to the CARs, I guess, once they get into the body and they're growing really quickly, they're recognizing those cells that shouldn't be there, and then they're bringing in all different parts of the immune system to help get rid of those cells that shouldn't be there. So they have a big sort of cytokine storm or a big inflammatory response. If you think that for when you just get a viral infection or COVID and your immune system's really flared, or you have an allergic reaction to something, that's sort of similar to what we see with this, but it can be quite sort of significant, and patients can require some intensive care support just for that initial period when the CARs are really doing their job. One of the other effects that we need to watch out for is neurotoxicity, which I'll talk a little bit more. And another side effect that's probably become more well-known in the last few years, which is called prolonged cytopenias, or when patients have sort of reduced blood counts as a result of this treatment. And then I'll go on to the late effects in the coming slides. So as I mentioned, CRS, or cytokine release syndrome, is a really common side effect that we see after we give the CAR T cells. It, in some ways, is quite reassuring to us because it's telling us, even though patients feel really miserable, and they say, "Oh, Maddie, please don't tell me that this is a good thing." I always say this is a sign that the CARs are doing what they should be doing. However, in saying that, we've absolutely had children who have not had any symptoms of CRS, and the CARs are still absolutely doing what they need to be doing. And we very much know that the degree of inflammation or the degree of CRS very much correlates with potentially patients who have active infection at the time. That's what makes it a little bit worse, or definitely is related to a patient's leukemia status before they come in for CAR T. So we'll always do a test of the bone marrow to check before they come in. If there is sort of a substantial amount of leukemia, there's more work for the CAR T cells to do, therefore there's more inflammation that's going to be caused. Whereas if there's less leukemia present, then there's usually less risk of the toxicities. And we usually see these symptoms occur sort of 3 to 7 days after we give the infusion. And so that's when children will come into hospital if they develop a fever, just generally feeling unwell. But some children might need some oxygen support or potentially some blood pressure support, which might mean they need to go to ICU for a period. And there are, I guess we're very good at the management of CRS. It's very standard across the world, around the world, and we have a very good treatment of a medication called tocilizumab that we can give to sort of reduce that inflammation without causing any of the effect on the CAR T cells. So it's just a bit of an uncomfortable period for patients, but I guess it reassures us that this is what we want to sort of be happening. One of the other side effects that I think the acute side effects that is less straightforward potentially and harder to predict which patients will present with neurotoxicity but is a side effect called ICANS, or called immune effector cell associated neurotoxicity syndrome. And this is when we see, so remember that I said that the CAR T cells are really good at crossing over into the central nervous system, which is excellent for children that have leukemia in there, but we do see some degree of inflammation in the nervous system, which can cause some of these side effects. So this requires really close monitoring, and if you have any suspicion of neurotoxicity, we definitely will admit patients for observation and do imaging if we need. We typically tend to see neurotoxicity after CRS, so usually around sort of 8 to 10 days after the infusion. And most commonly, we just see sort of children become a little bit delirious. They become quite emotional, a little bit forgetful. Usually watching them on their iPhones and iPads is a really good way to assess how children are, because some will sort of forget their code for their iPad or forget what they had for breakfast, or it can certainly become much more significant, and patients are sort of definitely not recognizing anyone, and it can be really frightening for families. And the treatment that we will use in that situation is we will usually use a brief period of steroids. And most commonly, these cases of neurotoxicity will self-resolve when the inflammation settles down, and we don't necessarily need to do a lot, but we would need to watch really, really closely and make sure that we're excluding any other cause for this neurotoxicity. And we know that, especially also in the adult clinical trials, that there's not necessarily been any long-term sort of neurocognitive effects that we've seen from patients that have had the neurotoxicity, but that's something that obviously is being watched really closely because it's a bit of a newer therapy. There definitely are some more severe cases of neurotoxicity that are rare, but they are reported. So we always need to be really closely watching out for these things. And that's really important when sort of children are reintegrating back into school. But the neurotoxicity is most common to occur sort of within 60 days of the CAR T infusion. So we really closely monitor our patients neurologically. Obviously, in children, it's much harder to do your standard neurological testing, such as, what day it is, who's the Prime Minister, those sort of questions. So we have specific tools that we use for paediatric patients that are more about sort of watching what they're doing, noticing any changes. We do a lot of education with patients and families. Doing handwriting is really excellent in paediatrics, because that can be sort of one of the first signs that can become a little bit abnormal if some neurotoxicity develop. And a lot of our children take great joy in developing their writing sentence for the day. And I always like to put this one in, because this was one of the best ones that we got. And this child was laughing hysterically in the wait room before coming in for their consult. So always brought a lot of joy, this child, doing a neurological testing. But something really important for families, I guess. Families and bedside nursing staff are the sort of the first that are acknowledging any of these symptoms. In terms of the prolonged cytopenia, so this just means children that have reduced blood counts, so potentially reduced hemoglobin, platelets, white cells and neutrophils for a certain period after their CAR T infusion. We tend to see this from our experience in children who have been quite heavily pre-treated, so potentially have had a lot of prior chemotherapy, have had potentially a bone marrow transplant recently, or potentially their blood counts are a little bit low before they start the treatment. And so of our 50% of children who have good CAR persistence, or their CARs are staying around and haven't gone on to need any further therapy, we've seen these sort of prolonged cytopenias in about a third of these patients. There are some things that we can do, but it usually is just time, and the counts will recover. But in some children, it can take up to sort of 1-2 years after their CAR infusion. Generally not always at the situation where we're needing to provide transfusion support, but we certainly have had children that are requiring transfusions for sort of the months in the post-CAR period. So that's something that we watch for really closely, and obviously need to be monitoring closely for infection and continuing on sort of infection prophylactic medications for these children. So the monitoring of these children, so in I guess the first time that we're assessing these children to see if they've had a response to the CAR T is day 30, so 30 days after we've given the CAR T infusion. We do a bone marrow and a lumbar puncture test, and we want children to be in remission by day 30. And we know the CAR Ts work quickly, and if they're working, children should be in remission at day 30. The other way that we monitor for CAR T cells, so we don't specifically have a test in Australia, a blood test that can tell us, yes, this is exactly how many CAR T cells are circulating in the body. But we know that the CAR T cells should forever be targeting the B cells because they've got the little receptors on the outside and they're forever targeting the B cells. They're recognizing the CD19 on the outside of the B cell. So we can do a blood test called lymphocyte subsets that looks to see if any B cells are present. And if there's no B cells present, that is excellent. That's exactly how it should be. And if some B cells start to come back, that's when we start thinking about that the CAR T cells are getting a little bit tired and potentially we need to think about other treatments. So that's sort of our first disease reassessment. And then we're still watching the full blood count really closely. Most children have recovered their blood counts by about day 60, but not all situations. But that's the time point at day 30 when children can start thinking about getting home to their referring centres. And then we just have a collaborative approach and monitor these children with their primary team. So we do a lot of telehealth follow-up. And just in terms of the frequency, I get asked this question a lot about how often we're monitoring disease status. So we do very regular bone marrow and lumbar punctures on our children post-CAR T. So every month for the first 3 months. Then we drop down to every 3 months between month 6 and 12. And then we do an 18-month and a 2-year bone marrow lumbar puncture. And if everything's looking excellent, then we don't do any further bone marrow and lumbar punctures after that time point. And obviously monitoring the B cells is really important. So we do that blood test every month until 1 year post-CAR T, and then every 6 weeks from month 12 to 24. And then we really drop back the frequency after that because we know that if the CAR T cells are still circulating, particularly after 1 year, definitely by 2 years, we're very comfortable that they're circulating sort of long term. So just a couple of late effects in my last 5 minutes. Obviously, we can't get away with, probably made CAR T cells are really excellent. But there is one side effect that is, I guess, a significant late effect that we need to think about. And that is that while the CAR T cells are forever targeting those B cells and patients aren't making B cells, one of the really important jobs of your B cells is to produce immunoglobulin, which is a really important part of the immune system that particularly helps to prevent chest infections, sinus infections. And so we can't be without them forever. Well, we can, but we need to replace the job of what they do. So the B cells, they make immunoglobulin, and we can replace that in 2 ways. So we can either do a monthly intravenous infusion of immunoglobulin, which is taken from healthy donors that are rich in sort of antibodies, and we can give that once a month via a cannula. Or in majority of situations in the paediatric setting, we train our paediatric patients and their parents to administer the immunoglobulin subcutaneously, and that's done once a week. And so that is a sort of long-term consideration for these children, which is obviously not insignificant. But I find that our patients tend to just work it into their weekly routine. I mean, I'm sure obviously it is a bother, but I guess the one thing that we know about CAR T, and potentially there might be something in future, another way that we're able to replace the immunoglobulin. But we really find that maintaining those good immunoglobulin levels really, really helps to reduce chest infections, sinus infections. Sometimes when we find maybe some of our adolescent patients get a little bit busy and not necessarily giving their immunoglobulin, we do tend to see a bit of an increase in their chest infections. So really important to maintain those good immunoglobulin levels. What else that I guess we can't ever miss with children who have had CAR T therapy, and although we know that with CAR T, we don't really expect too many significant end organ toxicities, so we're not particularly inducing significant cardiac, respiratory, renal toxicity from the chemo before the CAR T or the CAR T itself. But we can't forget that many of these patients have been very heavily pre-treated. So we can't forget if they've had a transplant before, their routine transplant follow-up, and their routine chemotherapy follow-up. So we're really closely monitoring for other late effects potentially that we might see from their prior therapies. I get asked a lot about the risk to fertility from CAR T. So we know that the lymphodepleting chemo that we give before the CAR T infusion, it doesn't add any additional risk to a patient's fertility. And to date, there's no known impact of the CAR Ts on fertility. However, in saying that, in majority of situations, these children have been heavily pre-treated, as I mentioned, and there is a risk to their fertility from prior therapy. So we need to watch really closely for these, for fertility, refer to the gynecology team for females, the endocrinologist, and really keep a close eye on patients' fertility and if there's anything we need to aid as they're potentially reaching puberty. And I guess we are offering fertility preservation for a lot of children in the paediatric space, but that is usually something that is offered prior to their other therapies that they've had sort of in the lead up to their CAR T. And one of the other late effects that we really need to monitor for is secondary malignancies, and whether this be from prior therapies. There's no sort of convincing cases of the CAR T itself causing any secondary malignancies. There are in the adult population some more cases of secondary myeloid malignancies, but we haven't seen these in the paediatric setting to date. So we're more commonly looking for malignancies as a result of prior therapies. So not something that we see a lot in the paediatric setting, but something that we're always sort of monitoring for. And then I always like to talk a little bit about vaccinations. So I guess when a child undergoes their childhood vaccination schedule, what one of the important things that your B cells do is make antibodies, I guess, to those vaccines so that you're able to recognize if that virus, if a child is exposed to that virus in future, they have antibodies to that virus from their vaccinations. However, when children have no B cells, they don't have the ability to produce antibodies to those vaccinations. However, children are usually getting some protection from the donors from their immunoglobulin against common diseases that we have vaccinations against. So for children who have ongoing CAR T persistence and are receiving immunoglobulin, we don't proceed with childhood vaccinations. We do the flu vaccine and the COVID vaccine only. But I appreciate that there's very different practices at different centres, and something that is very much sort of being looked into in the current times. And then my last slide is just about children returning to school and kinder. So for children who have had an allogeneic bone marrow transplant, there is certainly a lengthier period that children are away from school because of being immune compromised for a long period. So it's really uncommon for a child post an allogeneic stem cell transplant to be back at school within sort of 3 months of their transplant. CAR T is a little bit different to that. And so we tend to, it depends how motivated the child is to get back to school. Some children ask me to write a letter for an exemption for like a year. And some children are really eager to get back to school. So it really depends on the child. But usually anywhere from sort of day 30 onwards, providing the patient's blood counts are okay, that's when we think about returning back to school. And we've just started with a lot of our children having involvement from our really great neuropsychology team, and we're doing neurocognitive assessments on all of our children that are having CAR T therapy, and that really helps to integrate sort of back into school. And I know in the adult setting they're doing a lot of neurocognitive assessments on the adult population to look for sort of longer term impacts on cognition. So we just need to make sure that we're appropriately informing the schools when children are returning back, what things to monitor for. Obviously, we're still watching for neurotoxicity until around day 60 post-CAR-T. So just really needing to provide all of that information for children returning back to school. I think I've stuck to my time allocation. Hopefully that was interesting, and please let me know if you have any questions. And this is just my acknowledgement slide. I'm sort of one person in our huge team that is delivering CAR-T therapy. So yeah, definitely can't do it without our whole team and the patients and families, of course.
Thanks, Maddie. That was absolutely brilliant and so comprehensive to have gone through the whole process for our audience. I'd like to invite people to put their questions in the Q&A or even to share some of their some information in the chat. There's a message in the chat from Jess who said, thanks, Maddie. That was great. Thanks, Jess, for your feedback. So, Maddie, just while we're waiting for people to pop some questions in the Q&A, I've just, kids are quite phenomenal, aren't they, in terms of their resilience? How do you go about ensuring that the kids who are undergoing CAR-T are appropriately educated and prepared for the process?
Yeah, I think it's really tricky, and particularly tricky for children that have come to us from other centres. So the patients that we know really well and have previously built good relationships with, I think we sort of understand in a way what level of information that these patients that is helpful for them. So I do, I think the videos that we've made, I'm super happy with those, because I feel like a lot of the questions I get from patients are, what does this look like? What does this look like? What is it like taking the VAS cath out, rather than about the CAR sort of on its own. So I think they will be really helpful. There's also some really useful websites from the US hospitals that have sort of been doing CAR for a while that I tend to direct families to. But I think it's really tricky when we prepare children that we potentially haven't met before. So we rely really heavily on, I guess, with the families appreciating, I guess, how much they want to know. The adolescents tend to want to know a lot of information, and we tend to meet, a lot of them ask to be met on their own, to sort of talk through what that looks like. A lot of the time for the adolescents, I get asked, like families, the children might meet on their own and say, how do we know if this isn't working, and what would be the next steps? So I think it's really case by case situation. What I will say is this cohort of patients usually have been in the hospital system for a long time. So we have sort of 5-6-year-old children asking extremely intelligent questions. So I think that, yeah, it's very much a case by case basis, but I think these are patients and families who know the system well. A lot of the time families have read all up about CAR-T before they even get to us. So I think it's sort of individual, and then obviously using the families, I guess working with the parents particularly about how much information they think is appropriate to share.
Great, thanks, Maddie. There's lots of great feedback. I'm not sure if you can see it, but lots of thanks, lots of congratulations on your amazing work, and people saying how helpful the information is. There's a question here from a mum by the name of Karen.
I can see Karen. Hi.
Yeah. She has actually said patient number 6.
Yes.
So you might be aware of who she means. Thank you, Karen. It's always really lovely when we get to connect with people we know. But Karen's question is, are CAR cells being manufactured in Australia?
Yeah, good question.
Now?
They were for a period of time, but that has since stopped. So they were being manufactured at paediatric, but that stopped for a little period. But the plan is to restart. But at the moment, they're just being manufactured in the US. Because I guess there's a lot of other CAR-T products currently being manufactured here. I guess for trial purposes. But at the moment they're in the US. But I will say it doesn't actually change anything in terms of the time frame. So a lot of families will say, because the cells are going to the US, does that mean that it's going to take longer for the cells to get back? But it actually doesn't add anything to the time for the cells being shipped away, because we get them here in a day. It's actually the 4 weeks is the time that it takes to actually grow and manufacture the cells. But yes, they definitely will be manufactured here again in future, but not currently.
Great, thank you, Maddie. So there's a question from Mary, someone who'll be familiar to you, someone very famous in the paediatric oncology setting. And Mary asks, what is the youngest and oldest patients over the last 5 years? So obviously in pediatrics.
Yeah.
And what has been the longest time that immunoglobulin replacement has to be used? And she said, great presentation, Maddie. So oldest and youngest patient so far you treated and period of time on immunoglobulin.
The youngest patient that we have treated was 6 months old at the time of apheresis. So I guess there's no criteria for the younger age group, but you have to be able to collect the T cells, which was quite challenging with the 6-month-old patient, but absolutely possible. So the youngest patient was 6 months, and the oldest patient was actually 19 when we treated them on the trial, and is now 5 years on immunoglobulin replacement. So that's the longest to date. Yeah.
Thanks, Maddie. So there's a question here from Alan who says, thanks so much. And Alan's curious to know more about your neurocog, so neurocognitive and development baseline assessments and what's involved, and same with post-infusion to help with transition back to school.
Yeah. So we are very lucky to have a really excellent neuropsychology team here, and they have a particular interest in the CAR patients. So we are now doing baseline neurocognitive assessments. What that actually involves, I would need the neuropsychologist to be online, but it's very extensive. It's sort of, they do 2 hours at a time over like 2 or 3, sort of like 2 consecutive sessions. And then we are doing them at usually around day 100, sort of 100-ish post. And a lot of the time we've been doing them on these children anyway who have potentially had cranial radiation, TBI. And then what they do is develop a report that is really helpful for, and this was actually some of the funding from one of the Maddie Rewalt Vision like organization as well, which is amazing. They've been doing in our post-transplant patient population as well. And they prepare a report that is sort of individual to the patient, and it would say things, for example, as, you know, child prefers written instruction over verbal instruction, can only sort of manage concentration for 1 hour periods at a time. And then we have a meeting with the school and with the teachers, with us at the neuropsychology team, and sort of help to transition that way about what they've found that is most helpful for the patients. So we've just sort of started doing that. We didn't do that from the start, but we have just started doing that recently, which is really helpful, I think. Yeah, hopefully that answers the question.
Thank you. So there's a question that's come up around the risk of cells being contaminated.
Yes.
Yeah, and look, this actually came up in the adult presentations as well.
Yep.
And look, I'm conscious that you can't talk specifically, Maddie,
Yep.
because, you know, it's very, you know, it's infrequent, and there can be different reasons. But do you have any comment about contamination of cells?
We've had one situation. It's not frequent. There is, so I think the risk of they quote sort of a manufacturing failure risk is sort of around 10%, and that can either be because there's not enough cells that are harvested, whether there is a lot of leukemia that's in the product, but I think we've sort of worked ways around that. If you've had recent sort of infection that can reduce your T cell count, that can make it trickier. But contamination is far less common, but absolutely possible. And I guess just like any situation, it can potentially sometimes be a situation that is an infection that the patient has themselves at the time. And we had that happen, and the patient actually didn't have any symptoms of this infection at the time that they were aphorised, but then developed symptoms the following day. And then subsequently, we got a call from the manufacturing facility to say that the product was contaminated with this infection that there was really no way of knowing at the time because the patient was well. But I guess it's just can be potentially be an infection that the patient has themselves, or it can be something that can be contaminated in the process. Obviously, the actual collection process or the handling of the cells. It isn't that common. That's really unfortunate. I'm sorry to hear that. Hopefully their cells are just able to be recollected. We've never had any issues with recollecting the cells, but obviously it's really annoying because you have to, the child has to go through another collection, but they absolutely will not use those cells for manufacturing if they're contaminated.
Yeah, thanks, Maddie. That's great. Thank you for answering that question. So Alan has another question, which is great because I love it when someone asks a question and then your answer inspires a second question.
Yeah.
So Alan asks, how do you monitor and assess for neurotoxicity in young people?
I'm going to bring my slide back up.
Oh, great. Okay, good.
Oh, sorry, I could see that question, so it's all good. How do we monitor? So I'll show you. We have particular assessment. Can you see that slide?
Yes.
So we have particular assessments for paediatric patients who are less than 12. So you can see on the right, we have this scale. It's called the Cornell Assessment of Pediatric Delirium. And so you're doing they're pretty much just looking at how a child is interacting. So we did this with our patient that was sort of 6 months old. Are they aware of their surroundings? Are they coming to clinic and they're just really restless, the parents can't console them? Are they much less active than normal? So we do rely a lot on parents in this situation, noting any changes, but this will provide a score. And then that allows us to grade it to what grade of neurotoxicity it is. So that's why it's so important. And in pediatrics, we spend a really long time in the workup for CAR, really assessing the neurological status of patients and getting an idea, particularly even of what the infants are like. But there are particular scales for under 12s. Yeah.
Brilliant. Thank you. And Ellen, no need to apologize. Ellen said she's an OT working with CAR T adult patients.
Oh, that's a good question. So it's a great question.
And, certainly feel free to reach out and we can put you in touch with people working in CAR T, Ellen. And look, this will be the last question because we're just about finished. Maddie, you've been so incredibly popular. So there's a question here the question is, I work in tissue donation, but curious about CAR T. I have two questions. What are some of the malignancies CAR T are used for in the pediatric population? So you've mentioned acute leukemia. And after CAR Ts are infused, how do you monitor disease progression?
Yeah, so good question. So the malignancy, so the only available product that we have in pediatrics at the moment is for B cell, so relapsed refractory pre-B ALL. That's the only one that's a standard of care product that's been developed for pediatric patients. We have a T cell CAR coming, a CD7 T cell CAR coming in clinical trial in the next couple of months. That will be in the pediatric population, but that so far is all in pediatrics because we're waiting for these to be trialed in adults and then to filter down to the pediatric population. There's a lot of work going into CAR T in brain tumors, acute myeloid leukemia, but nothing in pediatrics that has yet made it to the early phase trials. It's sort of all in vivo trials at the moment. So much more to come. I think in about 10 years, there'll be so much more CAR T available, but just sort of obviously a little bit slower developing in pediatric world. How do we monitor disease progression? So we do very regular. There's two things you look at post CAR T. One is you need to obviously look in the bone marrow and the CSF. So we do really frequent bone marrow aspirates. and lumbar punctures to look for evidence of leukemia. And we send all of our bone marrow samples to the CCIA lab in Sydney, who can do a really sensitive PCR test also that can detect really, really, really low levels of leukemia. So that's the first thing that we do very frequently up until 2 years post-transplant. And then if everything's looking good, we don't look in the marrow anymore. And the second thing, we do a blood test that looks at the B cells. So because the CAR Ts are targeting the patient's B cells, and it can't differentiate between the leukemic B cells and the healthy B cells, it targets all of the B cells. So our immunology lab have a blood test that we do, and it tells us if any B cells are present. And if there are no B cells present, that's excellent. That's what we want, and that's what we expect, because the CARs are working and they should be recognizing and targeting all those cells. But if the CAR T cells are getting a little bit tired, then the B cells can slowly start to come back. And that doesn't necessarily mean that the patient has relapsed, but it gives us potentially, if that's happened in the first 9 months or so post-transplant, post-CAR, that gives us a little bit of that makes us a little bit worried, and that's potentially in the background when we might think about going to transplant or something else. Yeah, so those two methods are how we monitor for disease progression.
Thanks, Maddie. That was incredible. And thank you for all of your questions, everybody. You've been a brilliant audience. I'm going to hand back over to Ange. But before I do, I'm just going to give the Straight and Marrow a little plug, because our current season is on CAR T therapy. So obviously this webinar will be up on the Arrow site at some stage, and she'll probably let you know. But if you are craving more information about CAR T, please get onto the Straight and Marrow, which is on Apple Podcasts and Spotify, to listen about CAR T and allogeneic BMT. So thanks very much, everyone. Over to you, Ange.
Oh, thank you so much, Maddie. You are an absolute wealth of knowledge, and we are so lucky to have had you on tonight. That was absolutely brilliant. I loved it. So I'm sure all of our attendees loved it too. I will just say to everybody that please, if you do need to reach out to Arrow, we are here to support all our BMT, stem cell and CAR T patients and their carers. So you can always jump on our website at www.arrow.org.au, or of course email us at info@arrow.org.au. At the end of this webinar, which is right now, we have a very short survey. We'd really love you all to fill that out if you can. It does help us with any future webinars. It does allow you to give us a little bit of input into future topics, etc. So it's completely anonymous, so please feel free to say exactly what you want. We do love feedback. And also, if anybody did need to reach out to their teams and need any further support from Arrow, please contact your social worker. And we're really grateful that you attended tonight's webinar. The recording will be available to everybody. You will receive an email with the link once it's finalised and up and running. So look out for our next webinar. I think it's the May the 27th. And until then, thank you so much for joining. Thank you again, Maddie. You were brilliant. Thank you, Yvonne, and we will see you all soon.
Bye, everyone.
Bye, everyone.